Hi, everyone. It's Stephanie with the Patient Story, and I am so thrilled to be introducing the people part of our conversation today, our guests. There's Donna, who will be sharing her incredible story and what she's gone through with multiple myeloma and the incredible, spirit with which she's done that. And her doctor, her specialist, myeloma specialist, Dr. Cristina Gasparetto, who's the director of the multiple myeloma program at the Duke Cancer Institute. So welcome to you both.
Thank you.
So before we dive in, there's a lot to talk about. Let's start with you, Donna. I want to just ask you to try and talk about yourself, the way you would just someone new, about who you are, Donna, outside of the cancer context.
Thank you. Well, I am a grandmother, first of all, and an athlete. I like to go out and work out all the time. And I'm a former product line manager in a computer networking industry where I spent most of my career. I've been retired for several years and have traveled most of the East Coast.
Thank you so much for sharing that. And Dr. Gasparetto, when I was first talking to Donna about her, experience here, she said, she's a force to be reckoned with, that Dr. Gasparetto, and also just how indebted she was to the fact that you had called her in the beginning when she wasn't sure, whether to call you or not for treatment. I mean, that's something else because we know how busy you are. So, what drives you to do this for people?
I feel like I spent half of my life with this disease, and I just want to help people. I just want to win. I don't know if I can win the war, but a lot of battles with my patients, and I want them to know that I'm there for them. It's the only reason why I'm doing it. If not, there will not be a purpose, Yeah.
Well, thank you for sharing that. I appreciate, again, you both being here. So let's dive right in. I want to start with, we're not going to spend too much time with the first line treatment, but Donna, I think people will be interested in understanding how you did discover that you had myeloma and when it was, and how you dealt with that.
Well, I'm a fortunate person in that I discovered multiple myeloma before it had done any structural damage. I just discovered it through a blood test and rapid bone degeneration. And it turns out one of my markers is in my blood. So it can be tracked and monitored by blood tests. So I was lucky.
And just wrapping that part of it. So that was June 2012 to May 2013. You had undergone several different therapies. How did you find that you were in remission, and how did you respond at the time?
Well, unfortunately, I find out I'm in complete remission with a bone marrow biopsy. And so it's not a fun way to find out. But, and it was 11 months when I was in complete remission, but I continued with a maintenance program. It doesn't end as soon as you get in complete remission. It's just that I got to move back home. So the bone marrow biopsy can determine if you're MRD negative, minimal residual disease negative. And it's, the quintessential test for the disease. The blood test just tells you whether or not it's time to check the bone marrow.
Well, thank you for running us through that. And for the maintenance, were you on Revlimid? What was the maintenance?
It was Velcade and Revlimid. So it was pretty intense for a maintenance program. And I had some bad reactions. I ended up discontinuing after 8 months because of the reactions.
What reactions were those?
It was severe neuropathy, other stomach issues, other things. Yeah.
Right. Okay, perfect. And so now we've set that landscape up. Donna, I know you didn't have additional treatment through 2013 into 2017, the end of 2017, so about November. What happened at that point where you realized I'm going to need to go back into treatment?
Well, I'd been getting, I can't remember if it was monthly or a quarterly blood test. The longer you go without any evidence of the disease, the farther apart are the blood tests. But the blood test started showing an increase in my myeloma markers. And so I knew something bad was happening. And finally, in 2017, after monthly tests, it was determined that it was at a point where we needed to respond to it. What I found is that in general, my oncologist, and mainly I've had two, Dr. Barleghi and Dr. Gasparetto, they'll let you enjoy your life fully until it's absolutely necessary to start the treatment. So if it's just growing slowly, they'll give you a chance at, not having to be tethered to a hospital.
Which of course is a huge, decision. I understand in talking to a lot of people, both patients and, oncologists, it's that balance of quality of life, being able to live life, and then, making sure that there's no progression or, attacking the disease. So Dr. Gasparetto, on that note, and again, with all of this discussion, when I ask some of these questions, I know they're broad, but in general, what are you looking at when you want to decide whether to restart treatment for somebody?
Well, we take into account, again, a lot of factors, right? And one of the most important is how long the duration of the first response was and how aggressive the genetic of the myeloma. So if we are dealing with a patient with high-risk myeloma based on the genetic, we generally need to be a little bit more aggressive, and we can wait because the myeloma will cause more damage very quickly. But if a patient has, a slow progression with what we call the standard risk myeloma, several years after the initial therapy, sometimes we watch and wait a little bit longer. Because we know once again, that the moment that we start therapy, there is no way back, right? We have to continue. So we follow some patient, for example, some patient evolving a few years after transplant, 4 or 5 years. Sometimes we don't start therapy right away. We watch and wait. And if we have, start to worry that the clone, that the myeloma is progressing more rapidly, then is when we need to start therapy. But that doesn't apply to all patients. If we have a patient with aggressive myeloma from the very beginning, we probably will not be able to wait so long. So again, we take into account a lot of factors and the disease, the patients, the prior therapies.
So with Donna, and again, thank you, Donna, for coming out, sharing your story so openly, because I think it's a great, thing for someone to be able to see an example. So here we are, it's Dr. Gasparetto, it's Donna, and you're having this conversation. What was that treatment decision conversation like for the both of you? And we'll start with Dr. Gasparetto, and then Donna, I'd love to hear from your perspective.
Again, I think with Donna she was able to remain in remission even without the major maintenance for a few years, a fair amount after the transplant. So her myeloma was progressing slowly, but then at a certain point, you need to initiate therapy no matter what. So when you have the hint that the myeloma will start to progress, and then you have to choose therapy based on the prior therapy received. Because Donna was treated at the Little Rock, she went, a tour de force, the total therapy, and then she experienced a fair amount of toxicity with Velcade, with bortezomib, with Revlimid. You need to switch class, you need to change, you need to choose a drug with very effective, but with different type of toxicity. She will not, she could have gone back to the Velcade, but with a peripheral neuropathy was not an option. So you have to modify the regimen, again, based on the prior therapy, how long the duration of the response, and the toxicity.
Wonderful.
Yes. Yeah.
Okay, great. And normally, we don't talk about age and things like that, but in this context, we do, because we know that the median age of diagnosis for myeloma is somewhere like 69, 70. Donna, may I ask, when you were first diagnosed, how old you were, and then again at relapse?
You're going to ask me to do math here. 68, it was 9 years ago. So what does that make me? 15 So I was young. I mean, in terms of the lottery, I was young. I wasn't the typical patient.
That's right.
And very fit, right? Donna is it's very fit, and it makes a lot of difference. And I always tell patients that, it's not the age, is also your performance status, and allows us to be sometimes more aggressive. And we do have something in common, Donna and I. we both, actually, we still belong to the same cycling team. And being a cyclist, Donna was coming up in, good fitness. And that's the reason why she was able to cruise through the total therapy, with all the aggressive therapy that she received. And it makes a lot of difference.
Yeah, no, I'm just so glad you're talking about that, because overall, for people just to understand, there has been a shift in terms of the paradigm, the philosophy. You've got to hit it hard with a good, to get that deep response, or the best response up front,
and
right?
Back then, when Dr. Berloghi, established that program, we didn't have anything available, right? Because even the thalidomide came out from his group, from his team. It was the first clinical trial in myeloma patients with thalidomide. It was published in 1999. So before that, we just had chemotherapy, and the idea of using the high intensity comes from him. And but now, 20 years later, we do have a lot of new drugs, new agents, a new mechanism of action.
Great. And that's so promising. And that's part of why we do this too. So thank you, Dr. Gasparetto. Donna, you had said that right off the bat, when you were first diagnosed, you were 59, young, fit, you were ready to go, and you wanted the most aggressive approach. Then you went through this, you, even with the Velcade and the Revlimid, did deal with severe enough side effects with the neuropathy that you felt, gosh, this is a little bit too much. So knowing all of that, and with your experience with such an aggressive first-line treatment, when this all happened, you're talking to Dr. Gasparetto about how to, attack the myeloma again. What was top of mind for you? What was the most important? And were you thinking, I want to be just as aggressive, or were you thinking, I also need to balance my quality of life?
Getting that diagnosis that it was back is so traumatic. It's almost worse than the first time. And my first thought was, I'm not going to even end the chemotherapy this time. If they want me to stay on maintenance for 20 years, I'm going to stay on maintenance, because it was so important to me to keep the beast asleep, if you will.
Thank you for sharing that. That insight. I'm sure many people feel the same way you do. And so with that in mind, Dr. Gasparetto, what helped you decide? I know Donna's first, if I'm correct, was then the carfilzomib, the Kyprolis, the Revlimid, and the dexamethasone.
Donna and I started to talk a little bit after that. She was followed initially by another oncologist who was not super specialized on myeloma, right, Donna? And so we started to talk and having a conversation. We got linked by a friend of ours, actually, and another cyclist, and we started our conversation. But the carfilzomib, I think the decision was because the toxicity that Donna had experienced with the Velcade. So going back to a different, again, we are using the triple combination in the relapse setting, right? And so at that point, she needed to go back to a triple combination effective. She was off therapy for a while, so she progressed off therapy. So going back, circling back to the Revlimid, that made absolutely sense. So you have again, you could have gone back to the Velcade, but not due to the toxicity. So the Caprolis with the Revlimid and dexamethasone was a very important combination established. We had data from a randomized phase 3 trial showing the effectiveness, the fact that it was effective, and the durability of the response was quite impressive. And again, the reason why we choose very aggressive combination, even in the relapse setting, because we have learned with time that we can treat the myeloma suboptimally. The myeloma, unfortunately, will develop the resistance very quickly. And so we want to go out of the gate very aggressively.
Yeah, I appreciate that, because again, it's highlighting a sort of shift here in the approach. So we know we have different classes of drugs, right? We won't get into all the names and everything, but if someone's not responding well, whether it's efficacy or side effects, it's too harsh.
Yeah.
Do you replace that one? I mean, so do you go to a different class of drugs in the combination, or can you use a different drug in that same class to see if it, might be different for a patient?
So for a patient developing resistance, we like to make the class switch, or go to the next generation, like with the IMiDs, we go to the Revlimid, to the pomalidomide, but we like to make what we call the class switch, absolutely. Yeah, and to try to attack the myeloma at a different level.
Yeah, it makes sense to switch classes of drugs.
Yeah.
Right? One's not working if it's not working with myeloma. But how about with side effects? Is it the same?
Yeah, well, every drug comes with baggage, right? And we have learned with experience. And it doesn't apply to all patients. So it's very interesting. There are some patients that are doing phenomenally with a combination, and other patient that they start to have toxicity from the very beginning. So sometimes we just have to try, and then if it doesn't work, we make the adjustment. Sometimes those modifications is enough. Sometimes we have to completely switch to a different drug. So again, it's very subjective. It's patient by patient, and we try. If you look even in the clinical trials, we follow the patient, how many had to discontinue because a certain toxicity, how many had to have those held or those modifications. So that is becoming part of treating patients with myeloma. I have a phenomenal team at Duke. I have some incredible APPs, PA and nurse practitioner working with me there. I call them they are my front line, because they become so used to this drug and they know what to expect. And there is a lot of education for the patients too, because we want to them to be aware, right? So they can come back to clinic and talk with us, and so we can make proper dose adjustment. Even with the Velcade that the Donna experience, and it doesn't work, it's not written in stones, right? But sometimes we've learned that sometimes holding the Velcade, making those modifications, we can manage the neuropathy. It doesn't work for everybody, so it's difficult, to say I'm going to do this and it's going to work. It's not fair, but definitely.
But it's on the table as an option to try. And whether it works is, of course, up to the individual patients. So Donna, at the time you weren't working with Dr. Gasparetto yet, but then you're on this, what they call triplet, right? So it was a 3-drug therapy. It was from November 2017 until June 2018. High level, I'm not going to try and make you remember everything, but do you remember in terms of, okay, this is your first treatment, foray back into getting treatment again, what that experience was like, and if you had a lot of side effects you were dealing with, and if you were, what they were.
I think the side effects of chemo are like childbirth. You forget it, so you can go to the next one. But yeah, the first week when I was in chemo, I was just devastated and having a little pity party inside infusion. By the second week, I had this attitude that me and my oncology team were going to fight this together. So I adjusted to the whole concept of it. And I don't remember the specific symptoms I was feeling, but from a Facebook memory, I know that it was making me feel not as good on the day or two after, and not as strong. But really, the childbirth thing, I pretty much forgot all of the things that I didn't like about it. What I did like about it, it works for me. It knocked my cancer back. And so in 2000, I started in 2017. By 2018 and early in the year, my M spike had gotten to 0. So
I wanted to ask you about that, actually. You know, you'd already had this resolve once, and then you're hit again years later. You go through therapy, you have that attitude of, we're doing this together, which is great. When you heard that news, though, of the M spike hitting 0 again, what was your reaction?
I was ecstatic. I was joyful. I believed I had a touch of invincibility and a heck of a lot of luck.
I was wondering about that just because, it's curious. Is it, okay, you had gone through this experience before. What was it like sort of the second time to be able to, feel that? So you're saying you were ecstatic. You had mentioned if they wanted me to be on a treatment forever, I would be on maintenance forever. What was the plan after that? That was about June 2018, according to your timeline.
Well, and in fact, I didn't follow through with what I said. And when it came to maintenance, as soon as I could travel, I did. So, I had one plan right in the beginning. And by the time, I was 3 months with MRD 0, I went off treatment to travel and to see things. Today, I think I would do that differently. Just because the longer you stay on maintenance, the longer the beast stays asleep. And it's hard putting it to sleep the first time. So you better keep it asleep.
Thank you for sharing that. That's great insight. I do want to go back to that, though, because you made a decision to live life, right? Which I don't think anyone could feel badly about, in terms of, well, yeah, that's why we do this, is to be able to do things in our life. And so we will talk about how you regret that now, but at the time, if you were to highlight the decision of what else drove you to do that, is there anything else you'd like to add?
Well, this is relevant to the whole experience all the way up to today. But I realized that I don't have to travel to Niagara Falls and Acadia National Park to live life fully. One of the things I figured out this time around, since I am tethered to Duke Raleigh with weekly chemo, is there's a lot of stuff within a 3-mile drive for me. So I've just made it simple for me to experience all of that without having to drive a long distance and live fully without, giving up all that much, just different location.
And so what I'm hearing is you figured out living life, yes, is really important. That's the quality of life, tending to yourself, feeling very alive, but that you figured out how to do it without having to stop therapy.
Exactly. Yeah. Exactly. That was a big thing for me. And I'm a slow learner. I just figured it out last June.
Hey, I'd say that's fast learning for a lot of people, actually. So, we're going to dive into that more a little bit later on, but I appreciate your candor and your honesty there, because, yeah, a lot of people can learn from your experience.